This is Rob McMillan for CLS 202, the paediatric assessment. So as in any job, I would consider scene safety, consider PPE. In the times of COVID, I would consider wearing a mask as well. All those standard precautions. Upon arrival, I greet with the mother. Hi Mum, how are you today? My name is Rob, I'm from the ambulance service. Can you tell me what happened today, please? And Mum would say, oh, my baby fell. I mean, it's not unusual for a baby to fall, but the baby fell down a number of steps, may have hit its head. She's unsure. The baby's been crying a little bit all morning. She really just wanted to get the baby checked out. So once I've seen the baby, I'm just first assessing if there's any major bleeding and addressing that to start with, and then just having an overall impression of the baby from standing away and not actually touching the baby. So I can see the baby is breathing quite easily because the baby's crying. The baby's very vocal, so the baby's alert. Looking for their work of breathing, so looking for the rise and fall of the chests, seeing if they don't have any clothes on, you might see the accessory muscles working, or you might see some pursed lips or something like that if they were having difficulty. Generally checking the circulation of their body by looking at how well perfused they are, if you can see their extremities, and later on, once the clothing is off, you might see some peripheral signs of circulation. So then you would start at top to toes with the baby once you've done your primary. So after introducing myself to the mum, I'd introduce myself to the baby, try and be at the baby's level. So I'm talking to the baby, but not trying to be too over the top and confrontational, trying to be relaxed as possible, and making sure the baby stays in mum's arms so the baby feels comfortable. So looking at the baby's airway, she was having difficulty breathing. You would use your torch, which I have here, just to check their airway, making sure they're not choking on anything, particularly their own tongue. Looking for their breathing, assessing their rate and rhythm and effort in their breathing. Once you've gotten permission from mum, you might be able to open up the baby's top or remove the top just to see if they're using any accessory muscles to help them breathe. And also be listening to all their lung fields. So maybe perhaps on their back if that gives you a clearer indication, or just on the front of the chest. Circulation, be assessing the pulses for rate, rhythm and effort, quality, and also looking for the skin colour, the temperature and the cap refill on the baby. Determining the GCS, if the baby is conscious and alert, then they've got a GCS of 15, but we would use the paediatric GCS if there was any signs that the baby was not GCS 15. Then we would look for a pupil assessment, looking for equal and active reactive to light. So maybe just using this as a little bit of a toy just to get the baby's attention rather than sort of being too dominant to scare the child. Then once we've exposed the baby, we can do palpate the child and just look for any tenderness or soreness, any bruising or anything like that, particularly around the head. That would be of the greatest concern and the highest of risk, but also around the abdomen region, where all vital organs are. Then when we talk to mum about whether the baby's been on any medications or has got any allergies, a little bit of a history if the baby's been healthy and well, or whether the baby's had a lifetime of being in the hospital at the other end. I think talking about when the baby had last eaten, when the baby had last been to the toilet, whether they've got a wet nappy, and any particular events leading up to the baby actually taking that fall. Was it simply just unsupervised, or was the baby, was there any other extraordinary circumstances there? Awesome, thank you.